Okay, let's talk about the method first, going into history. Different books, different textbooks are going to have a different method of teaching how you go through the process. Remember, orthopedic assessment is a systematic process. What I'm going to be teaching you guys is the process that I've developed over the years. I've been practicing and teaching orthopedic assessment. I find it works very well for me, and I found that it's very easy to memorize steps and follow through them. So, method that we're going to be following, again, it is systematic and it is sequential, so we need to do our best to do so. And I want you to perform it as close to the same order every single time. And that's particularly important when you're learning. After you've gone through the process and you've got a strong grasp of orthopedic assessment, you can play around with the order you do things in because you see how everything interconnects. But while you're learning, really try and follow this systematic process. Once you become familiar with the process, it's second nature, and as I said, you can play around. And the acronym is HOMS-P. That's history, observation, movement, special tests, and palpation. And we're going to go through each one of those aspects of orthopedic assessment. And then once you learn what they are and how they're done, after we get into individual dysfunctions, we will go through each dysfunction in that order. We will learn the history, observation, the movement, special tests, and palpation. We're doing our best to follow a sequential order. History is our subjective information. Well, not ideal. If you only do one part of the assessment, it should be the history. And again, it's not ideal, but keeping in mind that time is usually difficult to manage, so you only have time, it's history. After that, we get into our observation. This is visual cues that help identify presenting complaints. Begins from the moment you first see your client, includes posture, gait, bruising, pain behaviors. It's everything you see. That's observation. Now these are objective findings, so we go in O of your SOAP notes. Movement, test range of motion, functional movements, myotones, any type of movement that you do. We are going to be focusing almost entirely on specific planar movements. If you're on to the side, if you're on forward, flex your neck. However, I'm also going to be talking about functional assessment, how to perform a quick, easy functional assessment based on home activities. Special tests. We use special tests to evaluate the likelihood of a specific condition. And then palpation, assessment using touch. It's done periodically through the assessment and continually during treatment. So palpation is on its own. It's kind of separate because that is anywhere it fits, so long as you've got permission. During the history, I might start to palpate. Sometimes, not often, but sometimes I might start to palpate to help give me a better image. Of course, it's going to be done throughout all of the treatment, but you might palpate as somebody lifts their shoulder. You're going to pay attention. So what's said is massage therapy is essentially glorified palpation because really all we do is feel. We're feeling what it's like.
What is myotone?
We'll talk in more detail, but it's a dysfunction in muscular contraction due to a neurological issue. It's a
not firing properly.
Yeah, that's right. It's a muscle or group of muscles innervated by a specific nerve root, to be specific.
So it's looking at if there's a dysfunction in the nerve root.
Yeah. So that's the HOMS-P method. And then we'll go through it a million times. When I said I will repeat myself 6 to 8 times a day, this is what I will repeat. So long as you understand the process. History, observation, movement, special tests, palpation. That encompasses the entirety of orthopedic assessment. That's everything. Start with number 1 skill, how to ask good questions. We'll talk about the questions to ask in a moment, but first, how to ask questions. Asking good quality questions that are going to lead in a productive direction, again, is a skill that takes time. As I said, it's arguably the most important aspect of assessment. your ability to communicate and ask questions. Review the health history form, because that will give you a good starting point of questions that you should ask. They should be asked in a logical sequence. This is a skill that requires practice. For example, you have likely learned the acronym Lord McFarlane. So you will ask L, location, O, onset, R, radiation, D, duration, M, mechanism, I, intent. Right, you know the acronym. If you don't, we'll discuss one. It doesn't actually make sense. It's not logical. It's just a really great acronym. Lord McFarlane. You can remember a name, so you know the questions to ask. And I will talk about the use of acronyms, and you should use acronyms. When you are asking questions, sometimes it makes sense to say, what brings you in today? Oh, you're bringing up shoulder pain. Well, how did it happen? Not when did it happen, how did it happen? That's mechanism of injury. So sometimes you do jump around a little bit, and eventually we want to ask them in a logical sequence as much as possible. Don't ask a question if you don't know why you're asking it. A good example is the F in Lord McFarlane's frequency. What does that mean? Like, what is frequency? Any ideas?
Like how often the symptom occurs?
Sure. Like how often, as in what time period?
Yeah, like how many times a day does it bother you?
How many times a day does it bother you? That's perfect. So it's within a 24-hour period. Why does it matter? What does it matter if somebody's like, oh, it hurts worse in the morning? And I'm not picking on you. You don't have to answer. What I mean is, knowing that you ask frequency based on a 24-hour period doesn't tell you why you're asking. What information? How does that help you? Anyway, just writing down it's worse in the morning. If you don't know what that means, why ask it?
But wouldn't that be helpful? Because it would be like, oh, maybe it's like a sleeping position thing. Maybe it's
Right.
a stiffness thing.
That's a good point, because now you're starting to get in why we would ask that question.
Or if it's the end of the day, maybe it's like overuse.
Bang on. Precisely. Precisely.
Severity too.
So-
Like how often is it happening to be like, is the severity getting worse? It could be like a way for them to identify whether you're being useful or not,
Yeah,
or whether your treatment is useful.
exactly. So that's a good reason to ask about intensity. And it's a good reason to ask about character. All of these questions, they have a good reason to be asked. But if you don't know that reason, don't ask. It'll just confuse you. It's information that doesn't add anything to your assessment. Ideally, you do know the reasons, and the ones that you both gave, phenomenal reasons to ask these questions. Communication style affects the interview, and that's something that you will build with time. You will have your professional persona, how you communicate with clients and patients. Do you walk in and you are the professional? You've got your jacket on, your lab coat, and then you sit down and you conduct yourself like the professional you are? Or do you come in with your kind of flowy hippie clothes and you're chill and it's like, yo, what's shaking? How you been, right? Nothing wrong with that. Nothing wrong with that at all. But your communication style is going to determine how things flow. I do my best to be as relaxed as I can while still being professional. It's a balancing act. I don't want to slouch in the chair and be like, so. But I also want to make sure that my clients feel very comfortable. So I'll sit down and just have a conversation with them. Like, hey, how are you? What's happening? So you'll develop that with time. In the beginning, the questions tend to be almost robotic. Almost. First impressions are very powerful in any industry, but in this one it's particularly important. You're building a very strong relationship. How you present yourself, it really does matter, and how you ask these questions matters. So keep that in mind, that your impression does matter, and build that skill. Another skill to build. Work towards developing an open demeanor, clear communication style, and you engender trust. And it's not automatic. You might have difficulty in clear communication. And if that's the case, don't worry about it, because it's a skill to build. It just takes time and practice. Be open, be clear. When you ask a question, find the way to ask the question that makes sense to you, and more importantly, makes sense to your client. For example, asking, what's the character of pain? talking to some sort of eccentric artist, they might be like, I don't know, kind of like a goofy character mixed with some Donald Duck. Like, okay, that's not quite right. So asking character, you might not work for you or them. So even though C, character, is one of the questions we ask, I might say, so can you tell me about the pain? What does it feel like? Could you describe the pain to me? And if they don't understand, I'll be like, is it dull, aching, sharp shooting, something like that. There are general questions to ask every single patient, and then specific questions to ask depending on the region. So there are questions everybody gets, and then depending, like you're not going to ask about, does it hurt to brush your hair if they're coming in with ankle pain? I mean, you might, but it doesn't make sense to you. So far, so good? Do not interrupt, but do not let the interview go off track. That's another skill. You're going to have your people who like to talk. You know the ones. You have your patients who come in and it's just talk. And you've been in there for 10 minutes and you haven't got any information. They're just talking. And it's very difficult because you don't want to interrupt, but you have to be on time. Sometimes you must say, I'm really sorry to interrupt. But they'll say, what brings you in today? I came in for shoulder pain and it's just been driving me crazy and it keeps me up at night, and that's a problem because when I'm up at night and I don't sleep well, I get really grumpy. And when I'm really grumpy, I start to just get so angry at my husband. Man, he did this thing the other day, and you're like, sorry to interrupt. You said your shoulder hurts. Right? It really does happen almost exactly like that. It might be an actual example. So try your best not to let the interview go off track, but that does take tact, right? If you start to feel it veer too far off track, particularly if somebody's talking emotions, right? Because it does happen. We're in an emotional setting and start talking about their feelings. Not really your place, so try to gently bring it back on track. Ask open-ended questions more often and close-ended questions when necessary. I think I'm going to talk about the difference between open-ended and closed, but in case I don't. Open-ended question is, what brings you in today? It's open-ended. Versus, are you here for knee pain? It's closed. A closed question has a yes or no answer. Do your very best not to ask yes or no questions. Sometimes they're appropriate, but do our best to let them fill in the blanks. Guide the interview with relevant questions. So ask your questions in a way that make sure it's pertinent and relevant to what you're getting at, and ask only one question at a time. So it might be, where does it hurt and when did it happen? What brings you in today? What part of your body hurts? Right? You might ask two questions. That sounded almost natural, right? It sounded like, that makes sense. You could ask, but don't. One question at a time. So far, so good. Listening skills. Again, we talked about this at great length in ethics last year. But one of the most important aspects of an effective interview or inquiry is your ability to listen and really listen. When you ask a question, you know the next series of questions you're going to ask, so you don't need to be thinking about the next thing you're going to say. That's what we do in a conversation, right? If you have poor conversation skills, you're asking a question or you're listening, just waiting for them to shut up so you can say what you have to say. And that's not uncommon in a conversation, not great, but in a clinical setting, really listen. Like eye contact, pay attention, everything they say. They'll tell you a lot. Try not to make judgments. Simply focus on the words they are using. Judgments are, what you did was stupid. Like, why would you do that? That's ridiculous. Don't make any judgment call. Pay attention to what's being said and what's being not said. I watch what people do with their hands a lot. As they're talking about their shoulder pain, the hand goes up like this. They start to rub their neck on something like, yeah, my shoulder's been bothering me. Or you might see them, they'll just suddenly rub, start to point to the spot. What brings you in today? You know, I've got shoulder pain and it's been bothering me for quite some time. I start to rub here and I might say, so I see you rubbing your shoulder. Is that a spot that's causing you troubles? So pay attention to everything. Pay attention to their face. Pay attention to their expressions when they're talking about something. When you talk about the quality of pain, if they actually think about it, they'll probably wince. What does it feel like? It's like brutal. It's like stabbing, nagging pain. So just pay attention to what's said and what's not being said. Good listening demonstrates genuine, empathetic interest. At the very least, if you don't care, act like it. And I'm not telling you to fake, but this job requires empathy, and it requires us to care. And if you don't care, but you act like it, weirdly enough, it doesn't take long before you actually do care. So genuine, empathetic interest is ideal. Really care. Nod and make sounds of acknowledgement. That's a pretty basic communication style, but when somebody's talking to you, don't just... Right, you're super uncomfortable. And even you're nodding, you're like, I get you. Stop looking at me. Like, I understand what you're saying. Right? So, do so. And it might not require reminding, and it might seem redundant to you, but yeah, give a nod, be like, yeah, I get it. Mm-hmm. Share their expressions. That's weirdly effective. Is when somebody starts to frown and their eyebrows go down, lower your eyebrows. Pay attention. If they're smiling, smile with them. You have no idea why they're smiling, but I guess they're smiling now. That's great. You're talking about pain, but you're smiling. I get it, I'm sure. Weird, but that sort of reciprocal acting makes people feel like, hey, we're the same, you and I. And it builds rapport very quickly. That's a rapport building skill. Oh, and on that, rapport building. Dress professionally. Again, we went through this in ethics last year. There's no such thing as a dress code in this business. You can really wear whatever you want, but there are better and worse things to wear. Ideally, you wear scrubs. Something that's, I don't like scrubs. I like a cotton t-shirt where I've got movement, but professional is fine. So dress professionally, that sets up a good rapport, and that rapport says this is a professional setting. That's what we're doing. It's professional. So start that. Use the patient's name when talking to them, particularly early in the interview. When you go out and meet them, and you introduce yourself like we talked about yesterday, you don't introduce yourself first. You know their name, right? You've got it on the form. They've booked with you. They've given you your name. So you go in and say, I'm Dr. Come on. And as you do the interview, you just throw the name in here. People love it. People love it. Match your patient's tone, tempo, and cadence. Don't be fake. But if somebody's talking slowly and calmly, talk slowly and calmly with them. And if they're a little bit more high energy, you can talk a little bit more high energy too. And it might seem false and fake to you, but again, this is how we build rapport. And our job, part of our job is to build rapport. People need to like us. I'm not trying to tell you to be fake so people like you. We're building a strong rapport relationship. Try to match their communication style, introverted or extroverted. And now if you are an introvert or an extrovert and you're trying to match the opposite communication style, this can feel very unnatural. But again, it helps people feel connected, feel like you're the same. And we can use these skills to lead as well. So somebody comes in and they're talking really high pace, they're going fast, they're breathing, they're really excited, and you join them in that excitement. But you want them to calm down. After you've joined them and you're on the same level, you can slowly start to shift the cadence and pauses you take as you speak. After you've matched them, you'd be surprised how quickly you lead, they will follow. Make eye contact, but don't stare, of course, right? That was uncomfortable, we're just staring. You make eye contact. And when you do make eye contact, you've got a great reason to look away, right? You're going to look at your notes, make eye contact again. When somebody's telling you something that's hard for them, make eye contact, but let them know it's okay to look away. It's totally okay. When people are communicating very strong emotional things that are difficult, is they might not want to make eye contact, but be there if they do. Use similar words. If they say that the pain is horrific and stabbing, then that's the word they've chosen. Let's talk about that horrific pain. Any questions there? Pretty straightforward. Do not tower over your client, sit at the same level or lower. So what that means is do not sit on the table and have them in a chair. Get them on the table and you're in the chair. Or if you have two chairs, you're both on the chairs. In my clinic at home, the interview process happens where we're both sitting down at the same level. The client would be where you are, and I'm about this far away and I'm sitting down. And we have this table not between us, but very specifically placed. And it's not between us, but it's there. It's enough to know, like, this isn't a friendly conversation. There's something here, but I don't want a table separating us. I also want to be on the same level.
Like what about like just one chair in the room, then you need to sit, you need to stand. You need to stand, and your client need to be sit.
If there's only one chair, they should sit on the table and you sit in the chair. Or they sit on the table and you stand. But if you're sitting on this table and I'm standing here and your head is here, it's still not good.
Mm-hmm.
You want your eyes to be at the same level or lower.
A lot of patients are comfortable in sitting on the table. I find like with my older patients will always go to the chair because they're not comfortable without a back support.
No problem. Grab another chair. That's more ideal. And if you can't, then be as casual as you can. For example, if you're sitting in the chair, and I'm not going to come close, I would lean against the table. Make sure I'm not stand. Be as close to sitting as I can be if I don't. And relax. Let them know. This is a conversation. With massage therapy, it really is about building a friendly relationship that still is definitive in the fact that you are the therapist and they are the client. Be genuine, be you. Really, be you. I've talked about how to build rapport and do things that you might not otherwise do, and that's important, but still, just be yourself. And that's one of the best ways to get the clients that you want. Because if you start acting like somebody you're not, clients might be like, yes, I love this therapist. He's the peppiest guy ever and does really deep pressure. Meanwhile, you're like, I just want silence and relaxation. But you've acted the part of this peppy, deep tissue therapist. Be you. Be genuine. Admit when you don't know something. You know what? I have no idea. I've never heard of that before, but don't worry. I'm going to look it up and I'll get back to you. And then actually get back to them. Relax. The first little bit, it might not be comfortable. Fortunately, in the student clinic, you'll have enough experience that by the time you get out into practice, and you should be pretty relaxed. But just stay relaxed. Stay calm. So far, so good. Any questions on all that? Let's talk about how to take good notes. We still haven't talked about the questions to ask. How to ask questions, now how to take high quality notes. Note taking begins with good listening, of course. We talked about that already. And in the beginning, have a dedicated notepad. I would strongly encourage you to not bring in your soap note, the treatment room. Have a notepad. And that notepad should just have scribbles in it or however you choose to take notes. And when you are writing it, just don't write any personal information. Don't write a name, don't write a file, don't write a birth date. It's got no information whatsoever. It's just notes. That's it. Yeah, no personal information. Great. Draw diagrams if you need, scribble, do whatever you have to do, and then afterwards, transfer your notes to the soap chart. In the beginning, it's so much information, and you don't know what's important. You're just writing down everything they say, or every finding you have. But then when you go back, it turns out half of the things you wrote down aren't important. So you just write down the most relevant and important in the SOAP chart. Use shorthand and common abbreviations. We'll talk a little bit about shorthand and abbreviations. Totally acceptable, but there has to be a legend. If you do use shorthand, then the file has to have a legend. These are common abbreviations. You don't need to memorize them, but some common ones would be like ASIS, anterior superior iliac spine. CC, chief complaint. HX, history. TX, ROM, right? These are common abbreviations and totally acceptable.
If they're common, do we still need to have a legend?
Things like, on this list, no. This list is taken from the medical profession. But, for example, FBSM, that's an acronym I've seen on a lot of massage charts. It is. Full body Swedish massage. That you'd have to write down somewhere if that's what you did on. So, niche specific. Deep tissue, DT. I don't know if it's on here. Yeah, deep tissue, DT, that's an okay one. So, they're a legal document. Write clearly if you are writing. If you're using an electronic health record, that's not a problem, but it needs to be written clearly, as clearly as possible. Don't spare any detail. Some clinics, like for example, Massage Heights, their SOAP note gives you like almost no space whatsoever to write anything. But you don't really need to, because you're not doing an assessment and you're usually just doing a full body Swedish massage. If you receive verbal consent, write down, make sure you wrote down. Ask permission to work on glutes, received verbal consent. Ask permission to work on chest, received consent. Cool. We'll get into the questions to ask. All right, asking questions. Time is the issue again. So knowing how to ask questions and which ones in which order is important. Ideally, you complete a detailed and thorough inquiry. That's an ideal world. If you cannot, then knowing the most salient and important questions is incredibly important. Now, there are many acronyms, right? We've talked about a few of them. Lord McFarlane is the one that you guys are familiar with, so that's the one I'll discuss. They can help you, but ultimately understanding why we ask each question is more important. So learn your acronyms, but they're easy to learn the acronyms. The why behind them, that's the part we'll spend a lot of time on, and that will probably be the rest of the class today, is talking about the why we ask individual questions. So the very first and most important questions, this is your list of, if you only ask a few questions, these are the ones. Where is the pain? Location. Easy enough. When did it happen? When did you first start to notice the pain? How did it happen? Mechanism. What makes what makes it worse? What makes it better? And what does it feel like? And if you only ask a few questions, let them be these. With skill and really understanding your physiology and what causes injuries, this goes a long way. 85% of your entire orthopedic assessment is within your history, is within the questions you ask. And of that, another 85% is found in just these questions. I'm just going to swing ahead a few slides. Right. Now let's talk about them individually. Where is the pain? Location. Get them to be specific. If they say shoulder pain, great. Left shoulder or right shoulder? Left shoulder. Where exactly is the pain in the shoulder? Get them to point. It's around here versus it's right here. What question? It's around here versus here. I know exactly what it is. Well, not exactly, but I've got pretty high likelihood if they say it's right here, it's probably the transverse humeral ligament. maybe bicipital tendinosis. Versus, it's around here, that's a little bit more complicated. It could be bicipital issues, it could be anterior deltoid issues, it could be fascial issues. But one question, point to the location of pain. I've narrowed it down now to 5 possibilities. Or 2, if they point one spot, 3, if they say it's a region. So you see one question, I've eliminated so many possibilities. And again, specific versus a region. Or maybe they'll say like this whole shoulder area, or back here. So getting them to point to the location. It's really deep, I can't quite figure it out. Even that tells you something. Now, where does it hurt? And they're like, you know, I just don't, I can't. All right, based on my knowledge of physiology and pathology, if they can't pinpoint it, I got a pretty good suspicion where it is, what's going on.
I'm just thinking for the what does it feel like to be character? If you're only asking like these 6 questions, why is that one of them? Like what does that tell you?
Right, we'll get into that one.
Okay.
Yeah, I can happily jump ahead though. What does it feel like? What's the character like? It's sharp. If it's sharp and specific, where's the location of pain? Here. What does it feel like? It's sharp. Probably a strain. Where is it? It's here. What does it feel like? It's kind of dull and aching. It's probably tendinosis. Where do you feel the pain? It's in my hand. What's it like? Tingling, neurological, aching, muscular, stabbing, strain or spray. So that character, the description, once we understand our individual pathologies, they have very typical characters.
We'll go through that again.
Yeah. As we go through each individual pathology, I'll describe all of this. If it has a character, I'll describe the character. And another important note is as we go through each pathology, I will say the most important thing your client is going to say is this. If they say these words, it's probably this condition. So I'll give you these little clinical pearls that if somebody says it's sharp and here, it's probably this. When did it?
Sorry.
Yeah, please.
Can you say it one more time? I really want to write
Which one?
those things, just like those characters that you just described and what they.
Right, if it's a specific spot and sharp, it's probably a sprain. If it's dull and aching, it's probably tendinosis or degenerative or overuse issue. If it's shooting, tingling, it's probably neurological.
Yes.
Now these exact descriptive words, we will see a little bit later as well.
Yeah. Okay.
Shooting, neurological.
Thank you.
Yeah, of course. When did it happen? When did you first notice the pain? This tells us if it's chronic or acute, and that's a very important one. Largely because it's going to determine the scope of treatment. Somebody's had neck pain for the last 20 years. It's going to be pretty hard to deal with, really. You can, but resolving 20 years of neck pain, it's not going to be a true treatment type of problem. So, versus, it just started 3 days ago. We know if it's an acute injury, then time might do the work for us, if we're lucky. Combine that with how did it happen? How did it happen? As we go through each pathology and you understand your physiology, you'll begin to understand how to put this together. How did it happen? You know, it happened, somebody will say this. When did it happen? It started about 6 months ago. Well, how did it happen? I was at work. Okay. What do you do for work? And they say, I work in a warehouse that has a bunch of heavy things. And it was inventory day. And I was just lifting up all day. My shoulder hurts, right? My shoulder hurts. It's like right here. Probably supraspinatus issue. When did it happen? 6 months ago. Well, what happened? It was inventory day and I was reaching up. Okay. We could ask more questions, but we know with almost certainty what they were doing was contracting the supraspinatus and abduction repetitively all day about 6 months ago. So they had an acute injury 6 months ago. So very specific and it's dull and aching. It's probably a degenerative issue within the supraspinatus. What makes it worse? Helpful. My low back hurts. Okay, great. When did it happen? You first noticed this. It started about a year ago. What happened? I was at work and I lifted down, I grabbed something heavy and I stood up and I just had this sharp, sudden pain. Okay, so we're already starting to build an image in our mind. We're thinking through the low back injuries. We're thinking then through low back injuries that are chronic but started as acute. Okay, what makes it worse is sitting makes it worse. Okay, what makes it better? Standing makes it better. All right, almost certainly a herniated disc. The likelihood of a herniated disc is like 90%. What makes it worse? Using it makes it. Somebody comes in. Let's start from another example. Somebody comes in. Where's the pain? So on this part of my arm. Okay, they're pointing to the extensors of their forearm. It's really only one possibility, but we're going to keep asking our questions. When did it happen? When did you first notice the pain? Oh, I can't really say. It's been a while. Okay, it's chronic. We don't have a specific time, but it's chronic. It's probably a degenerative issue. How did it happen? I'm not too sure. So we don't have any information that happens, right? When they don't know how it happened, this is usually when I'll jump into it. What do you do for work? What do you do for fun? What's your hobbies? But they don't know what happened. What makes it worse? Whenever I use it at work, makes it worse. And my job is I'm a plumber and I use screwdrivers. Whenever I'm using a screwdriver, it just drives me crazy. It hurts really bad. Okay, well with that, it's a repetitive issue of the extensors. It's probably tennis elbow. What makes it better? It's way better when you don't use it and put ice on it. Maybe it's inflammatory. Ice helps. So again, with each condition, we'll talk about these. You see how these few examples can take you a long way to understanding exactly what's wrong. And then what does it feel like? That's the character, which we've already been through.
When you're asking questions like this, when I'm in clinic, people often give you the answer that they think is the right answer.
What do you mean?
Like I've asked about pain and then I'll ask what does it make you feel better? And they're like, well, I ice it because I think that's what I should be doing.
Yeah.
Not necessarily that's what makes it feel better.
Yeah, okay, great example.
Like a lot of that throughout all of these questions.
Yeah, a lot of Dr. Googling.
Yeah.
Try and question through it. What makes it better? Well, I put ice on it. They can tell you if it makes it better. So when you put ice on it, does it help? Like, yeah, the pain goes away. Well, after you get that little bit of pain relief, how does it feel? The same. Ice the same. The thing about ice is of course, it's an analgesic. That's what it does. It makes pain go away. So you just ask a few more questions. And if they don't give you the right answer, just find another way to ask it. And if they don't have anything, if they're like, I don't know, it just hurts all the time. Okay, no problem. What makes it worse then? And when we ask what makes it worse, is you can ask, that's an aggravating activity. Is there anything you do regularly that makes it worse? When is it at its worst? And you say, what activity can you not perform anymore? That's an important one. Is this preventing you from doing anything? That's another way to ask the aggravating activity. You say, I just can't blow dry my hair. Or brushing my teeth is painful. Or it's like, I had to lower all of the cups in my kitchen because I can't quite reach that top shelf anymore. All of these examples are telling you that it's pain in either abduction or flexion. So you're thinking through those motions. Is that helpful? So you've asked these questions, then you'll ask the next set of questions. Oh, no, that's not to say these are not important questions. As we mentioned before, all of the questions you ask are important. The more data we have, the more accurate we'll be, and the closer we will be to the true condition, or the more likely we are to determine the true condition. So the next is going to be intensity. When we ask intensity, we have to be specific on how we ask. So one way that you might phrase it is like so. On a scale of 1 to 10, 10 being so painful you will go to the hospital, and 1 being almost no pain at all, how much pain are you in, or how painful is this problem? Now you see, I phrase it that way because if I say on a scale of 1 to 10 how much pain you're in, people might exaggerate. They'll say 12 out of 10. Or they might be saying, it's a 9 out of 10. Now, a 9 out of 10 for me means I'm this close to going to the hospital. But a 9 out of 10 for them just is basically them saying, it's really painful. It's really painful. So on the other hand, if we give them that scale and we say 10 means hospital, 1 means no pain, how painful is it? What you will find very fascinating, almost everybody will say 7. Because it's an interesting thing, when you give that scale, what would 7 mean? 8 means it's really painful. 9 means I'm 1 step away from the hospital. 10 means I'm going to the hospital. 6 means it's actually just slightly more painful than not that painful, because 5 and below means it's not that bad. It's totally tolerable. So 7 is the most common number. What I've come to do now is, on a scale of 1 to 10, 10 being go to the hospital, how painful is it? You can't say 7. Tell them you're not allowed to say 7. Give me a better number than 7. And they might say 7.5, 6. But regardless, how you phrase that is make sure that you give them the scale and then qualify the scale. And we do use that not only to determine, is this a very severe problem or a mild problem, but it also is very helpful to determine progression. Week 1, it's a 7. Week 2, it's a 6. Week 3, it's a 5. Week 4, it's an 8. Something happened. So in between week 3 and 4, we're going to ask a bunch of questions. What did you do? Not blaming like, what did you do? But what has happened that has increased the pain? And that's super helpful because now we can hone in on that causative factor, that etiology, which will help with home care. So that's intensity. Next, other treatments can be quite helpful. Have you had any other treatments? Have you had chiro, physio? Have you had massage in the past, for example? Now, the reason this is helpful is not because it's good to know if they have. It's because we ask them, did it help? For example, somebody comes in and says, my neck is really painful. We go through all of our questions. We're not too sure what it is. So have you had any other treatments? And they say, yeah, I've been to massage and I've been to chiro. And you say, how was massage? Was that helpful? And they say, not really. How about chiro? Very helpful. Well, that's actually very informative. Because there is a condition of the neck called cervical facet syndrome that turns out to be incredibly responsive to chiropractic adjustment and not at all responsive or minimally responsive to massage. So that question can help us determine what the problem is. And another way is, have you had any other treatments? Yeah, I've had massage in the past. Did it help? Not really. Why are they there then? Why are they coming to see you? If massage didn't help in the past, why come and see you? And you can ask that, well, if it didn't help, why are you receiving massage again? What's your intended outcome? And they might say, I didn't get along with my massage therapist. That's possible. Maybe they'll say, my old massage therapist left and I'm actually not here for you to fix a problem. I just want to relax, right? That can be helpful for determining other parts of the treatment. Cool. Medical history. Medical history is history of surgeries. They might have neck pain, and they don't know what's wrong with their neck. And how long have you had neck pain? I don't know, as far as I can remember, far back. Have you had medical history? Have you ever had any other injury with your neck? And they might be in their 50s, and they'll say, yeah, when I was a teenager, I got into a really bad car accident. Now, that's not to say the car accident is why they have a neck pain in their 50s, but it might lead you in that direction, so it might be helpful. Or maybe they have shoulder pain and they're coming in and the shoulder started to hurt last week after they painted their house. It's an acute condition. But you also discover that in the past they had a labrum tear repair in your shoulder. So they did have a shoulder surgery. I can tell you that it will complicate things. There's potential complication. Timing and frequency. So when we talk about timing, that frequency question, that's throughout the day. So I will talk about these frequencies now, but what I want you to know is I will reinforce this idea of frequency very regularly. When we ask about frequency, we would say, so during a normal day, is there any time of the day that it's worse? And I phrase it that way because if we don't, then they might give you aggravating activities instead. Meaning, during the day, is it worse or better? And they say, yeah, it's worse during the day after work. Okay, work is the aggravating activity. So, is there any time during the day that it's better or worse? Is it better or worse in the morning or in the evening? Now, part of the reason that helps is if pain, and again, I will repeat this, and I do have it on the slides, so you can write it down now, but note that we will go through this a lot. Pain that is worse in the morning, that gets worse throughout the day, and diminishes in the evening. It's an inflammatory condition. Pain that is mild in the morning gets better with use throughout the day, and high in the evening. That's a degenerative condition.
Sorry, can you say that one more time? High in the evening.
I'm going to draw a graph and I'll explain it. Yeah. All right, so here's the graph. I'm going to turn the light on so you can see this a little bit better. So on this side, this is going to be pain, and then this one is time. All right, so we got morning, that's AM, and that's PM. Pain, that is moderate. We'll go here, moderate in the morning. It gets gradually worse throughout the day, and then diminishes in the evening, and you've got bedtime. That is often inflammation. Alternatively, pain that is mild to moderate in the morning, pain that goes down throughout the day with use, and late afternoon, early evening, goes up. That's generation, also called osis. Tendinosis, for example. This would be itis, tendinitis. So that timing of the day is quite helpful for inflammatory conditions versus non-inflammatory conditions or degenerative conditions. And this is one good example, and it's a prime example, but what's important is different conditions are going to have different frequency patterns. Pain that comes and goes throughout the day, up and down, almost tidal pain is an example. And we will go through individual conditions that follow frequency-based conditions. All right. Next, we're going to ask about medications. Now, medications are going to be on the health history form. They certainly should be on your health history form. However, if they're not, ask about them. Some medications are more important than others. For example, asking about painkillers is important. are you taking any medications? And they might say no. Fine, let's qualify. So just to be clear, you're not taking anything like Advil, Tylenol, anything like that? Well, you know, I take Advil or Tylenol every once in a while. Okay, no problem. Have you taken any today? Yes, I took some this morning. That's technically a medication. Now, why would that matter? Who cares, right? It's so mild. It's an over-the-counter, non-steroidal, anti-inflammatory. Why would we care? Non-steroidal, anti-inflammatory. Some of the treatments that we do are very deliberately and specifically pro-inflammatory. Cross-fiber frictions, for example. We're deliberately trying to create acute local inflammation. So it's not like if they're taking an NSAID that's not going to work, but maybe it's not going to be as effective. So we want to create the ideal environment. Go ahead, Christine.
You mentioned yesterday, say if the the patient is taking the medicine for, I don't know what's that medicine, I want to figure out. We can treat them deep tissue.
Right.
Like,
if they're taking a narcotic analgesic, that's a prescription painkiller. A prescription painkiller.
could we get the
There's many names.
also
So it could be codeine, it could be Percocet, it could be gabapentin.
so for pain. So
For
if
pain.
What about Advil or
Right, so that's what I just explained. There's the over-the-counter medications. We can absolutely massage, but since they're anti-inflammatory, some of our techniques might be less effective. Not that big of a deal, but still worth knowing. On the other hand, if they're taking prescription painkillers, that's very important. Because prescription painkillers, and we're not going to go through the mechanism of action of all these different analgesics, that's a painkiller, but they all decrease pain. Now, our ability to communicate with our client is important because, as we know from our treatment class, ideal therapy occurs in this fine space between pain and discomfort. We want to be in that sensation zone where it's not painful, it's maybe not comfortable, it's not uncomfortable. So there's this narrow range we want to exist in order to create the maximal impact on the nervous system and overall physiology. But if they cannot sense pain, if their entire nervous system is artificially calmed down or dampened, then we don't have that same feedback. Which means I'm doing a strip up their back and I'm pushing in and saying, how's the pressure? And they're like, I don't know, it's fine. You could press more. And I press more, and how's that pressure? And they're like, yeah, more pressure is good. And then at the end of the treatment, they're black and blue and bruised because they couldn't feel the depth. I'm potentially over-exaggerating this, but you can see how we might do potential damage, yeah? So do ask about medications.
So then do we warn them, like if that situation comes up, it's like, I'm going to give so much pressure, but like how do we have that conversation, I guess?
Precisely like that. That's a great question. Is if they are on a narcotic, analgesic, prescription-based, or otherwise, if it's a recreational drug, we talked about this in ethics, you, the most part, can refuse treatment, but with that being said, if they are on a narcotic analgesic and they don't have sensation of pain, you would explain to them. Ideally, you come to me at the end of a pill cycle. So when that medication is going to be wearing off, come. So if they know they need to take a pill every 6 hours in order to manage their pain, no problem. Tell them to come in at hour 5. Take the pill 5 hours before they see you. So you see them when they're maximally responsive. And simultaneously, you'll have the discussion saying, it's incredibly important that we never, ever approach pain. You have to communicate with them. And you just make sure they're very clear on that. That we're not going to go anywhere near pain. Radiation. This isn't radiation treatment. This is radiating pain. I find radiating pain comes up naturally prior to asking specifically about it. But you can ask, does the pain radiate anywhere? Yeah, it starts in my shoulder and it kind of goes down my arm, or it starts in my neck and it goes up into my head. That's essentially telling me that there is indeed an active trigger point. Or if they say, yeah, it goes down my arm to my fingers and it's sharp and shooting and lightning like, it's neurological. I have pain that radiates down my leg to the bottom of my foot. Neurological. Expectations. This isn't something we talk about too much.
Excuse me.
Yes.
Something that I didn't understand. Never approach pain.
Yes.
What does it mean?
Right. So if I'm working on you and you're on the table and I'm massaging your back, I never want my treatment to be painful. So I would say, Lewis, what's important is you tell me if this hurts. And if it's even uncomfortable, you tell me. Because I never want to cause pain. So I never want to approach the pain. All right, so we don't talk a lot about expectations, but we should, particularly if you're dealing with somebody who has a very chronic injury. I've had cases where somebody's come in with very serious shoulder problems, like horrible adhesive capsulitis or shoulder impingement syndrome. And I go through the assessment and I say, okay, well, what are your expectations? What would you like? And they say, I've got a golf tournament in 2 weeks and I want to have my swing back. I want to be able to go play golf all weekend. It's like, okay, well, sorry, that's probably not going to happen. So we can adjust their expectations. And that's quite important because they come to you, and if you haven't had that discussion, and they're under the impression that seeing you is going to allow them to play that golf tournament in 2 weeks, and they don't, who are they going to blame? It's you. You didn't do a good job. If you have that conversation, you prevent that from happening. Let's go the other way too. Somebody comes in and they're dealing with hip pain, for example, shoulder pain, pick a region, doesn't matter. They're dealing with pain. And you've determined that it's a treatment you're very, very comfortable and familiar with. Maybe it's mild adhesive capsulitis. And you say, well, what are your expectations? And they say, honestly, I would love to be able to just do the dishes without pain. That's it. Like, period. And you could say, great, no problem. We'll get you there in a couple weeks. Just come back every 2 days. So you can adjust their expectations to the positive as well. You do want to be clear on expectations, that they know what to expect. And that comes with time, right, where you'll be able to say, we'll be able to resolve this in 2 weeks, or hey, this is probably going to take 6 months. That takes time and experience, but we can adjust expectations. How are we doing? Good. Mood. We're not going to ask about mood within, so I know this is an inquiry, but we can ask how they feel about their pain. That gives them the relationship to their pain. And it's more for us than for them in this case. And you don't have to ask this question. But asking about mood will help us know, is this person feeling optimistic about being able to resolve this condition or not? And if they're not feeling optimistic about it, it's very difficult to get them to participate in their home care. If they are optimistic, then working with them tends to be a pleasure. So again, it's largely for you to understand. Now there's this thing called a fear avoidance behavior or belief questionnaire, which we'll go through a little bit later on in a couple weeks. But it's a way to understand if they're fearful to do any movements or activities as well. I won't focus on that because I don't think it's a very relevant or important question. Anything in clarification? All right, our acronyms. This is the one you guys know, Lord McFarra, and each of the letters represents one of the questions. Location, onset, radiation, duration, mechanism, intensity, frequency, aggravating activities, relieving activities. Can't remember that other A, sorry, and history of previous injury or health history. Medical history. Another one, this is the one that I learned, is Lord McFartenfam. Same thing, location, onset, radiation, duration, mechanism, intensity, character, frequency. Aggravating activities, relieving activities, previous history of treatment. That's going to be medical history, family history. I can't remember that A for some reason. And then medications. It'll come to me.
What we learn is other is like O, right? Other. What we write in the what we learn before is like ROH, something like that.
I'm not sure which one you learned.
O means like other.
If you write it down, I could tell you what it stands for. What was that, Sage? Or stands for?
I was just wondering what of these do we have to know? Do I have to know these?
They're helpful.
Yeah.
What I want you to know is your first 6 questions to ask. Ultimately.
This is similar to like a TCM diagnosis of like aggravating, alleviating factors. Like,
Yep.
right?
It's the same thing. There's many acronyms, and I just put these up on the board to say there's a bunch of ways you can memorize these. A bunch of ways. I find in the beginning they're very helpful, but eventually they lose their helpfulness because once you understand why we ask each one of these questions, then there's much more of a flow.
Is the other A means like associated?
This could be an associate. Yep.
That's the text.
Yeah. Thank you. Associated injuries.
What is the C?
Character.
Right.
OPQRST. Onset, provoking factors, quality, radiation, site, timing, so, site, location.
Like looking at it, I'll be
Suddenly squinting at the board. My sight is fine, thank you.
Maybe
We can
that's
tell it's
today.
exam week.
What is the second R? The first one?
Relieving factors. So it's radiation and relieving factors.
But, I thought the 2 A's were aggravating and alleviating.
Nope. The other A is associated.
Oh.
Associated issues. All right.
All these acronyms.
Yeah, right. And again, those big 6, they're the most important. Those first 6 that we talked about. So these acronyms, I'm not going to test you on these acronyms. They might be helpful for you when it comes to clinic, where you could just write down your acronym and you can ask all of your questions. But what I will largely focus on is the why we ask questions. Because as we go through each one of the individual pathologies, I'm not going to use these acronyms. I'm not going to go through them in order. Because some things don't matter. Medical history doesn't matter for some pathologies. Family history doesn't matter for most pathologies. Radiation doesn't matter for a lot of pathologies, right? So it's not always relevant. Okay. As a reminder, notes on boundaries. We spent an entire 3-hour class on discussing this in ethics, but we'll discuss it very quickly. Remember, there is this thing called transference. That's when a client places heightened expectations on you. By discussing expectations early on, you can deal with this transference. Transference is most easily described as you are the one who is fixing me. I am giving you the power to fix me. And if I don't get fixed, it's your fault. So that's transference, and you do not want it. You don't want them to transfer their own sovereignty of their health to you. That's not your responsibility. You can also have clients who unload on you. That's not necessarily a bad thing if you've got the tolerance for it. I don't particularly have the tolerance for it. If somebody's coming to see me for psychological stuff in the acupuncture world, that's part of it, so no problem. But if they're there for a treatment and they're on the table and they just want to talk about how horrible life is, I don't have tolerance for it. So I stop it quite abruptly. My method for stopping it is breath. I'll be tolerant. I won't be like, shh, enough. No, I'll just wait and be like, okay. Let's just draw your attention to the shoulder now for a second, and I'll do a technique that's more stimulating, something that they can't help but be aware of. Not painful, but I'll move into a technique that draws their attention, focus on their breath. And every time they try and get back into the conversation, I will get back into the breath. I find that to be very helpful for myself. Clients do need to talk. Sometimes you're the only other person they have to really talk to, so they start to treat you like a counselor or a therapist, which you're not, right? I mean, maybe you do have a degree in counseling or therapy. If that's the case, by all means, go for it. But unless that's the case, don't be their counselor. Do not give advice at all. The only advice you should be giving is how to resolve that injured shoulder, hip, whatever. You don't need to fix anything. Sometimes you just need to listen. And if you don't mind listening, if they do have problems and they just need to talk and get something off their chest, and you're okay with it, go for it. Just don't say anything other than, I hear you. Right. Refer to a counselor if needed. No one, that's good. I refer to online counselors a lot because that's readily available. Pretty affordable for most people. And know your boundaries. Again, we did discuss this last year, and I really emphasized you should spend time on determining your boundaries. What are you comfortable with? What are you not comfortable with? And do not cross those boundaries. That's it. And if you are put in a position in which you have to cross or which you're not have to, but presented to in a situation in which it seems like you have to cross your boundaries, don't. Walk away. Just walk away. There's no need to cross your boundaries, but know where they are. During an assessment is a great time to establish boundaries. And part of the reason you can do that is during the assessment, assuming you have the time to do proper assessment, you set up the relationship. This is a professional relationship. You are here for treatment for this condition, and that's what we're focused on. And during that assessment, you have the opportunity to make sure the only thing you talk about is the condition at hand. And it is different than relaxation massage, because when people are relaxed, sometimes they just talk. Whereas if they're there for therapy, they're there, massage therapy specific, not counseling therapy, you can make sure that's all the session is. It's all about fixing that problem. Cool. Countertransference. When you treat the client like you're a therapist, I have worked in some clinics in which I have overheard this, and it's very unfortunate when you hear it. So do your best not to participate in this, and it's basically where you divulge personal information to your client and you start treating them like anything other than a client. Maybe they're a lawyer and you start seeking legal advice when they're on the table. Or maybe they're a doctor, or maybe they're, I don't know, an electrician, and you ask about wiring of your house. So they're your client and you treat them as your client. That's it. Don't, not to repeat myself too much, but your personal life is personal. Your personal life is personal. You're at work. You're not out for coffee. This is your job. And treat it as such. They're on their casual time. They're having a good day out. Maybe they're doing a, what's it called? Spa day? Not a spa day. Something like that. Treatment day? What's that?
Me day.
A me day. Yeah, maybe it's a me day. The day's all about them just feeling good. And they come to you and they just want to feel good. So they're having a great, fun, relaxed day, and they're willing to talk about anything, but you're at work. So do not participate in countertransference. They're not your therapist, they're your client. They should know very, very little about your personal life. Might not be the case for you. Maybe you are quite open and willing, and you're totally okay with being friends with all of your clients. If that's the case, and you are firm and understand that. You understand the complications come with those dual relationships. That's your choice. I strongly encourage you not to develop them. If you do start to treat somebody and let's just keep it to friendship instead of a romantic relationship. If you're like, I just really want to be friends with this person. That happened. You meet somebody, you're like, you're probably the coolest person I've ever met. We need to be friends. That's it. We need to be friends. Fine. go for it. But understand that that's a dual relationship, and in such a case, you need to be very clear on the professional relationship versus personal relationship, or cut off the professional relationship. It's doable, but again, you have to know your boundaries, where they are, and communicate them clearly. As far as your personal life is, be polite, not detailed. What did you get up to this weekend? None of your damn business. It's obviously not right. You know? I went to the mountains. It was lovely. How about you? That's polite. You know, it's fine. Went to the mountains. Dinner. I don't know. I watched Netflix. Whatever. You don't have to say nothing, but just limit the amount of detail you give. Dual relationships, we have talked about at length, they're very problematic. It's hard to keep track of them. I would encourage you not to have them, and if you do have them, be very clear. And don't hold on to things. It's not unusual to feel depleted after a session. It's not ideal, particularly in the beginning when you first start out. You might only have 3 people in a day, but you'll get home and you'll be wiped. Absolutely exhausted. And it's a strange thing because it's like, I don't know, I did 3 hours of work today, and it was pretty easy work. Like 3 hours of being in a quiet, relaxing room. Like, why am I so wiped out? Because you got dumped on for 3 hours. So taking on other people's emotional baggage is part of the job you need to be aware of. So don't hold on to it. Create a ritual for yourself at the end of the day. Find a way to shake it off, leave it at work, do whatever you have to do. One that I've heard often is the doorway matters. When you walk into that door holds on to whatever issues the person's talking about. And when you walk out of that door, the issues stay in the room. So you can use a doorway as sort of a psychological barrier. Visualization. I use visualization when I've got particularly challenging clients. I have a book. I'll write things in. I've mentioned it in the past. I'll write their issues in the book and what I'm holding on to. And I've actually started writing what my emotion is about it, like what it's brought up in me. This has brought up this issue of my past, like almost a diary. And put it on the shelf. When I put it on the shelf, I'm visualizing myself putting them on the shelf. Like, you stay there. Great. So far, so good. Any questions?
Can you touch base on that transference one when the client places you at heightened expectations?
Sir, what's your question?
Can we talk about the transference when the client places you at heightened expectations?
Yeah.
If they've done that with like your whole profession, how do you go back and maintain that boundary?
What do you mean you've done it with your whole profession?
Where like people are like, well, as an acupuncturist, you should be able to do this and this and this, and this is what I want of you, and previous treatments have provided me this, and it's like, does that make sense?
Yeah.
I don't know how to like go back and be like, well, that was all unrealistic, so.
Yeah, so just so I'm clear, you've got a client who comes in and it's maybe the first time seeing you, but they've been to multiple other practitioners, and they've been like, I went to this doctor and they gave me these herbs and I lost 30 pounds of weight in a week, maybe?
Yeah.
Yeah? Is that a almost too accurate example?
Maybe.
Yeah. It's very challenging. And the best you can explain is how you practice. You could say, I understand. And if that's the type of therapy and treatment you need, I would suggest you seek out that therapist. I practice differently, however. The way I practice is going to be like this. And then you lay it out. Like, if that's what this person had in the past, and they want it from you, and you aren't willing to give it or can't give it, just tell them, then you're going to need to go to somebody else. So that's the boundary. That's the transference, is you need to cut it off. No, this is me, this is my therapy, this is how I'm going to be doing it. Be direct. And with some patients, being direct is simply not possible. Like it's genuine enough because you attempt to be direct and 2 words into it you get interrupted again, you can't say anything, and you get demanded upon, like, no, just do it. I know it can be done, so you just do it. I'm here now, you do it. Be direct. I'm really sorry to disappoint you. I'm sorry that your expectations aren't being met and this isn't working. However, if we're going to continue to work together, then you need to be clear on what I am offering. And here is what I am offering. And they might never come back. And in such a case, probably not the worst thing for you. All right. Well, you know what? I think that's a good place to stop for the day. We're just about to get into observations. So instead, we will call that a day and pick up next week. Yeah?
Yeah.
Thanks for watching. Don't forget to hit that like and subscribe button. It helps our channel out a lot. If you like this type of material, check out these other videos on special tests within each region of the body, as well as some in-person recordings of me teaching orthopedic assessment theoretical concepts to a live class. If you would like to take a complete course on orthopedic assessment, check out the link in the description below and make sure to use the coupon code for a super awesome discount. In the course, we go through all of the theoretical concepts as well as how to assess every region of the body and identify many different forms of dysfunctions. All right, see you next time.